Good morning, class. It's chapter 7, and I'm going to go through physiological adaptations to pregnancy. I've got your PowerPoints uploaded on Momentum. You have your book in front of you, so hopefully you guys can go along, pause as you need to, make notes. If you have questions, go ahead and email those to me. I will have my laptop with me this weekend and can email you back anything that you didn't understand. And also, we can get together next week if you need to make an appointment with me. So I do apologize for having to miss this weekend, but hopefully this is something different way of learning, and I hope it's beneficial to you guys. So let's get started in chapter 7. Changes in the body system, the reproductive changes. You have huge changes in the uterus because that is where you're housing your growing baby. So the growth is predicted per trimester. The pattern of growth is predictable, and it helps to confirm estimated due date, estimated fetal growth, to make sure that the mom is continuing on that growth curve like we talked about last week. You also have contractility. So the uterus has to learn to contract in order to birth the baby. The forces from the fundus in the uterus are going to expel the baby, and this is practiced throughout the pregnancy by Braxton Hicks contractions. Now, these aren't real contractions, although they can be quite painful, but if they're not changing the cervix, they are not real labor contractions, but they can hurt. Also, increased blood flow. So the blood flow increasing to the uterus is to help it grow, help it stretch, to house your placenta, and just to help that baby form with the blood flow and the increased volume that the baby needs during pregnancy. So as you can see, here is a estimation of how that uterus should grow, and the numbers are corresponding to the weeks. So you'll notice about 12 weeks is when the uterus is coming up out of the pelvic bone. 20 weeks you're at the umbilicus, and this is also 20 weeks is corresponding to when the baby should start to move, to flutter. You're going to feel that quickening. And then the uterus will climb all the way up to the xiphoid process at 36 weeks. And then you'll see there at that dotted line, at 40 weeks, the baby drops back down, and this is called lightening. So as the baby drops down, that could also be an indication of imminent birth. You might hear someone say, "Wow, you've dropped," and that could be an indication that labor is within the next few days to a week or so. Now, other changes you will notice during pregnancy and delivery, labor and delivery, is cervical changes. So 3 different cervical changes that you will see: Chadwick's sign, Goodall's sign, and then you'll also see the mucus plug. That will be forming. So let's talk about Chadwick's sign. Chadwick's, if you think of the C and you think of color, if you think of like the old clothing company that used to send out that Chadwick's catalog, and all the colors, the clothes are really colorful. That's how I kind of remember that Chadwick's turns the cervix a bluish purple due to increased estrogen and increased congestion of blood. So the bluish purplish tint will be seen in the cervix, in the vagina, and also on the labia. So Chadwick's and color. Then you have the Goodall sign, which means that the cervix is softening. Obviously, you can't see a cervix soften, but you can feel the cervix soften. So you'll have that Goodall sign as well. And then you'll have a mucus plug formation. So this is a formation at the inside the cervix that keeps all foreign material, sperm, if you have a bacterial infection, any kind of germs from the environment, out of that nice sterile environment that the baby is in. And then it also helps to keep if the water breaks, if the mucus plug is still intact, it could help slow that liquid, that amniotic fluid from draining out. So once the mucus plug is expelled, then that cervix is starting to soften. You have that Goodall sign where it's softening, opening up, and usually that is an indication that labor is to come within the next few days. But mucus plug being expelled doesn't necessarily mean you are in labor. Here's a picture of a non-pregnant cervix. So you see that the vaginal lining is still kind of small, that you have the cervix, and it's pretty uniform all the way up to the uterus. But then in a pregnant cervix, you have opening. This white, opaque kind of color is the mucus plug. And then you'll notice that it's starting to swell, to become engorged, and that is just part of the signs of pregnancy. Different other body systems that you will see changes. The vagina and the vulva are also going to have changes, and you can read that there. The ovaries are going to change as well. You cease to ovulate during pregnancy because ovulation is to try to have fertilization and implantation. Well, once you fertilize an egg and it's implanted, the uterus is busy doing that. The ovulation ceases, and that's also not normally picked back up until a little time after you have labor and delivery. And breastfeeding delays ovulation as well, so that's why you don't have menstruation or menstrual period after you have a baby right away. The breasts are going to change size and color. You're going to have estrogen stimulated. That's going to make the mammary glands increase in size. Also, you're going to see that your breasts might tend to be a little bit more nodular. The alveoli are going to grow. Characteristic change, you're going to have progesterone is going to promote that growth. You're going to have the areola might become darkened. You will notice veins being more prominent. And also you can have that colostrum secreted. So sometimes you can actually leak colostrum and the beginning stages of milk formation even during your pregnancy. Here's a picture of the different changes. Non-pregnant. You'll notice that pregnant, you start to develop those veins in your breasts with increased blood flow to the nipple and the areola. The milk ducts need increased blood flow to produce the milk. And then the lactating, you'll see the nodules are very engorged. The areola is bigger, the nipple has gotten larger in order to provide nutrients to the baby. Okay, so the pregnancy is a systemic effect on the entire body. So that was the reproductive parts, but now we're going to talk about the heart, the cardiovascular system. So the heart is enlarged 10% to 15% during the first trimester. You could have alterations in the heart sounds, and that's just due to the extra blood flow, the enlargement of the myocardium. Blood flow is going to increase by 6 weeks gestation. So even at 6 weeks, even though the baby's small and the placenta isn't formed quite yet, that increase in blood volume is starting to happen in order to prepare for that need later on in pregnancy. You could have plasma volume increase 6 to 8 weeks until 32 weeks. So that's that extra volume that you're having circulated throughout the woman's body throughout her pregnancy. Red blood cells are going to increase by about 20 to 30%. So you might have that red blood cell increase, and you're also going to have that plasma increase. So that could, if you drew labs, you could have that physiological anemia, and that's to be expected during pregnancy. So if you did have that, the doctor could put you on an iron supplement in order to increase your iron for your blood volume. Cardiac output is going to increase 30 to 50%. So the workload on the heart is increasing by a half. So your heart is working time and a half in order to pump all that blood volume, that plasma, and your red blood cells all throughout your body. Vascular resistance is decreased during pregnancy. So that is why with the increase in volume, increase in workload, if a pregnant woman sits too long with her feet down or is on her feet too long, then you will have that pooling of blood and pooling of volume all the way down into her lower extremities or dependent extremities. And that's just the bad side of pregnancy, but that does correct itself. So you could have some varicose veins formation, the swelling, and what we would need to educate our patients on is just to elevate their legs, to stay off them as much as possible, especially if they're noticing swelling more often. And then also you're going to have effects on blood pressure. So anytime you have a pregnant patient, you never want them to lay flat on their back, because if you'll look in this diagram, you have the inferior vena cava and the descending aorta right on that spine. If the patient was to lay flat on her back, the weight of her uterus would put pressure on those main blood supply from the lower to the upper body and back. And that is where you get that they can become nauseous, they can become dizzy, but not to mention that you can also make their blood pressure bottom out. So you might, if you've got a patient laying in the bed, you always want to put a pillow up under their hip to tilt them one side or the other, just to keep that uterus from laying flat on that descending aorta and inferior vena cava, so that you don't cause you don't cause that to happen. So the best position for them to lay is left lateral. And even in your med-surg clinicals, you've had patients where you've had them lay to their left side to take their vital signs. So this is definitely something that you want to take into consideration when you have a patient lying in the bed. We talked about blood flow. You have to have increased blood flow to the uteroplacental unit, which is the uterus and the placenta. Skin also requires increased circulation because as the woman gains weight, her skin surface, the amount of skin surface is going to increase. She's stretching. Blood flow to the breast increases to start to initiate that milk production. And then also expanding the uterus partially obstructs blood return from the veins and legs. So the body is working that much harder in order to push that blood back up from the lower extremities back up into circulation. So that is that's why they need to rest, elevate their legs, try to stay off their feet, especially the further along in the pregnancy they are. There's different blood components, increased iron absorption, and then also increased clotting factors. So with increased iron absorption, increased clotting factors, one thing to think about is that pregnant women are at an increased risk for developing DVTs. You've got that blood pooling in their legs, not being able to come up into circulation, increased clotting factors. So it's kind of the perfect storm for a DVT to be formed down in the calves. So we need to make sure we know the signs to look for a DVT, which is heat at the site, redness, tenderness. You can do a Homan sign if indicated per policy at your facilities. I know that in the med-surg courses they're teaching you guys not to do that. In labor and delivery, we still gently assess that. But if you do find one, you definitely don't want to continue assessing Homan sign for the fact that you could actually dislodge that and it could continue on to places we don't want blood clots to travel. And the back on the woman lying on her back, let me go back. That's called the vena cava syndrome, where we could occlude that and that could cause issues. Just remember that. Sorry about that. Okay. Other changes in the body, respiratory. You can have hormonal factors. Oxygen consumption is going to be increased because if your heart is working overtime, then you have to also take in more oxygen in order to have oxygenated rich blood to be traveling where it needs to go. Hormonal factors, progesterone, estrogen is going to have an effect. For progesterone, this decreases airway resistance, so that's a good thing. But then estrogen increases vascularity of the mucous membranes. Capillaries can get engorged, and then you can also have congestion and higher incidence of nosebleeds. So that's due to the increased amount of estrogen that's flowing through the woman's body. So it's not uncommon to have women that are pregnant complain of stuffy noses, nosebleeds, and again, that's due to increased estrogen. The physical effects of the enlarging uterus, you're lifting the patient's diaphragm up. So if the diaphragm is lifted, then that puts pressure on the ability for the lungs to inflate fully, so they feel like they can't catch their breath. And you also have the relaxation of the ligaments around the ribs. So as the ribs relax and the diaphragm is up, just think about how hard that would be for you to feel like you're catching a nice big deep breath whenever you are trying to catch your breath. Sorry, I just heard something in the hall. I don't know what that was. Okay. Gastrointestinal changes. Appetite is going to change. They could have cravings, nausea, so that might inhibit them from eating well. The mouth, you can have excess salivation. So I think the only two people in our class that have had me in lab, which is Renee and Amanda, know that I don't do well with spit and saliva. And so one of the issues that pregnant women have is called, I'm never really sure how to say this, but the word is PTYALISM. Ptyalism. But that is excess salivation. And these women can have excess salivation up to the point where they are spitting cups of saliva out. And as they have that excess saliva and swallowing it makes them nauseous. So they don't want to swallow it anymore. They just try to spit it out. And it's disgusting and it grosses me out. But that is one of the things that they can have is that excess saliva. And then you can read in your book about the other GI changes. But if you think about just that growing uterus inside around your large intestine, your small intestine, your stomach, it's all getting squished up to your diaphragm, which is pushing up on your lungs, and you're not being able to catch a big deep breath. So if you think just about, all the displacement going on inside your stomach, like your abdomen, then you can see why it would be hard for pregnant women to want to eat large meals. So more frequent, smaller meals is better for the pregnant woman. Then you have the bladder of urinary frequency. You've got a baby growing, and sometimes it feels like they're jumping on a trampoline on your bladder, but that is some changes. Kidneys and ureters, the size and shape can change of the kidneys, and also the function of the kidneys. It's not uncommon for pregnant women to have recurrent kidney infections, kidney stones, just because the ureters are displaced as well, and that can cause urinary retention. UTIs are pretty common in pregnant women, so we have to make sure to educate them on drinking plenty of fluid, peeing as often as they need to in order to prevent that. Okay, so there's different changes when you look at a pregnant woman for her skin. They can have hyperpigmentation. So the melasma, which is called the mask of pregnancy, they might develop kind of look like sunspots, but dark spots, brown spots on their face, a little bit bigger than freckles. They look like sunspots. They also can have linea nigra. And over here, I'm going to click to the next slide to show you guys. The linea nigra is this dark line from down to the pubic bone, can travel all the way up the belly, up to the top of her fundus. And this is seen a lot with more ethnic women. African American women get this. Hispanic, Asian women, you can see that have lighter skin but darker hair. This seems to be more prominent, the linea nigra. It does go away after pregnancy, but that is one of the things that you might see. Let me go back a slide. Then you have the strigravidarium, which is stretch marks. So you have patients get stretch marks on their breast, on their belly, on their thighs, on their bottom, anywhere that they gain a lot of weight quickly. Their hair and nails change. So when you're pregnant, you have just gorgeous hair, gorgeous nails, because all those hormones are increased in your body. And that was when I had the best hair and nails, is when I was pregnant. 'Cause you have all those vitamins and minerals and blood flow, and you're taking more vitamins, so your prenatal vitamin. So that it would be another change. There's that picture again.